Hi, it's your favorite NP mentor here. So today we're going to talk about the difference between left and right-sided heart failure. I'm ready for this lecture and I hope you are too, so let's get into it. So I'm going to teach you my way, the favorite NP mentor way, how to memorize right-sided heart failure signs and symptoms. So my mnemonic is going to be WEAVE. Yes, W-E-A-V-E. W stands for weight gain. E stands for edema of the legs. A stands for ascites. V stands for vein distension, jugular. And E stands for enlarged liver or hepatomegaly. So first, before we memorize symptoms, I always like to go back to how blood flows, okay? So let's talk about what happens in the heart that causes these symptoms. Remember, the blood in the heart is always about forward movement. The pathophysiology behind all of these disorders comes from when blood is not moving forward. It's moving back, right? So let's say, for example, this patient has severe pulmonary hypertension, right? So now you have blood that's being regurgitated back into the pulmonary artery, which then goes back into the right ventricle. Once it hits that right ventricle, the right ventricle becomes enlarged if this happens time and time again. Now, that blood from the right ventricle is going to back up through the tricuspid valve. And where is it going to go? Into the right atrium. And then from there, it's going to go into the SVC, superior vena cava. Now, once you have an influx of blood being regurgitated back into the SVC, you're going to have jugular vein distension. So for me, this is V. Vein distension, jugular, okay? So then now, remember, blood is moving back, right? So once the blood starts moving back now, it's gonna come from the SVC and it's gonna go down into the inferior vena cava. And from the inferior vena cava, it's gonna go into the liver. And once you have an influx of too much volume in the liver, this is how you get hepatic congestion, right? And then the liver becomes enlarged. So sometimes in heart failure patients, this is why you see them have transaminitis, because of this hepatic congestion, right? So this is very common. This is one of the clues that you can use to tell you that this patient is in acute heart failure. The liver becomes enlarged. So once the liver becomes enlarged, you will have hepatomegaly. So this process just continues to progress. Now, these patients end up getting cardiac ascites. So what ends up happening is you start to have an increase in hydrostatic pressure. And once hydrostatic pressure increases, you start to have the shift of fluid into the peritoneal cavity. So really, cardiac ascites is essentially from increased hydrostatic pressure, which causes fluid shifts to move into the peritoneal cavity. And that's how you get cardiac ascites. And then you end up getting leg swelling. This all goes into the hormonal changes that also occur with heart failure that causes leg swelling. So you have these patients, they will have swelling in their legs and ankles and feet. Pitting just means that you can press down on it and you will get an indentation. It can be pitting or non-pitting, but yes, you will get edema of the legs. So let's move on to the left. So left, as we all know, left for lungs. Yes, I know. But I want you to understand why left is for lung, okay? So let's say you have a patient that has dilated cardiomyopathy, right? They have viral cardiomyopathy and their left ventricle is pretty enlarged. So what's gonna happen is that ventricle cannot pump correctly, right? It's weak. So you're gonna have blood, you're gonna have this big boggy chamber. Whenever you have dilated cardiomyopathy, you have a big boggy chamber that's pretty weak. And you're gonna have blood that's gonna be moving backwards because blood, remember, blood in the heart is supposed to go forward. You want everything forward. And if it's not moving forward, where's it gonna go? Back. So in your mind, you think about where does blood go if it's gonna go backwards. So it's gonna go back into the left atrium and it's gonna go back into the pulmonary vein, which goes back into the lungs. Now you have a bunch of volume that's being regurgitated back into the lung. So what do you think are gonna be some signs and symptoms that this patient will have? Crackles, shortness of breath, pulmonary edema, pink frothy sputum. Even if you think about like what happens if someone would have fluid in their lungs? Hypoxia. They will have orthopnea and they will have PND, paroxysmal nocturnal dyspnea. What's the difference between orthopnea and PND, paroxysmal nocturnal dyspnea? So let's talk about that. This is one of my favorite things to talk about. So orthopnea is when someone gets short of breath after laying in a recumbent or a flat position and it's relieved from them sitting up. So you always want to ask yourself, why do heart failure patients get short of breath when they lay flat? Why can they not lay flat? That's a good question, and I'm gonna answer it in just in case you didn't know. Anyway, so the reason why they get short of breath is because what happens is when you lay flat, right, you're increasing venous return. Now, if you have someone who already has an issue with forward flow of blood and now you're introducing more blood, then you're just going to make the symptoms that that patient is experiencing much worse. So you're gonna have more blood in the lungs, you're gonna have more blood in the heart, and all you will do is exacerbate or make worse those patients' symptoms. So this is why when they sit up, they are able to breathe because now you've decreased venous return. And just FYI, this is one of the reasons why we always ask patients, like, how many pillows do you sleep with? Because that's important. That's an indicator of how much volume this patient is developing. So if this patient told you, hey, you know, I usually sleep with 2 pillows, now I gotta sleep in a chair, they're pretty volume overloaded. They have no reserve to lay flat. They gotta sit up and sleep. That means that they are full of fluid and they need some aggressive diuresis, okay? Now, I digress. Go back to my point. So PND just means that this particular patient, they wake up after sleeping for 1 or 2 hours, short of breath, out of their sleep. They wake up gasping, like they're sleeping for 2 hours, 1 hour, and they just wake up and can't breathe. This is typical PND, right? So when patients have PND, when they have worsening orthopnea, or they're just worsening shortness of breath on exertion, it just tells you that they're becoming more and more volume overloaded and they need more diuresis. And then you'd also like to ask them, are they weighing themselves daily? These are just some questions that you can ask the patient to figure out how long has this been happening for? Did this happen acutely? Has this been happening over the last few days, few weeks? And this will kind of give you an idea of the time frame for this decompensated heart failure. Now, if you're enjoying my video thus far, which I hope you are, getting the value that I'm trying to give you, please make sure you hit that like button and please make sure that you subscribe because I have lots and lots more information coming your way that I know in my heart you're gonna love. All right, let's go. So quickly, I'm gonna go over heart failure with reduced EF and heart failure with preserved EF. So heart failure with reduced EF, which is systolic heart failure, just means that the heart is not pumping effectively. It's weak. So all the blood is just not coming out of the ventricle because the muscle is weak. And as we discussed in my prior video, which you should take a look at if you want to learn more, I'll get to that. You should definitely understand what are some of the causes for systolic heart failure, because then that will help you to understand why the patient is having some of these symptoms. Now, if you have a patient that has systolic heart failure, it means that this patient's ejection fraction is about 40% or less, okay? So why this is important to know is normal heart function, normal ejection fraction is 50 to 70%, okay? So let's say you have a patient now who comes in, right? And their ejection fraction is about 5%. This will tell you how bad this patient's heart failure really is. Now that number doesn't mean anything if you don't even know what normal ejection fraction is. So always compare what the patient's ejection fraction is to what's normal, and that will give you an understanding of how bad the heart failure is. Now, let's talk about heart failure with preserved EF. Patients who have heart failure with preserved EF have a ejection fraction that's normal, equal to or greater than 50%, 50 to 70%, right? So what happens with these patients is that sometimes with patients who have high blood pressure, they end up having LVH, which is left ventricular hypertrophy. So that muscle becomes pretty thick and stronger, because when you have high blood pressure, remember you have increased afterload, okay? So if your afterload is increased, it's going to be harder for the heart to pump blood forward, right? Because it's got to push against that resistance. So this is one of the reasons why patients with high blood pressure that's not controlled end up getting heart failure, okay? So that's heart failure with preserved EF. I want to thank you for watching my video. Make sure you subscribe. Bye.